next topical onychomycosis drug that has been approved recently. And let's take a look at that. But before we do that, I just want to discuss a couple of minutes for what does the boron does. So boron has a unique bonding orbital configuration, and it has one empty p orbital that gives us a chance to form a new bond, and that gives us sort of an exploitation of how we can add drugs there and how they bond and make that tetrahedral stable complex. And that's what the boron platform provides us. The drug can be anything. It doesn't matter what the drug is, as long as it fits into that platform. So in this case, also there's concern about boron and the toxicity of the boron. Actually, boron is in food. We eat it every day in the vegetables, nuts, and the fruits. About 4 milligrams a day, we consume it. And I remember when I was a fellow up in Wisconsin with Dr. Mose for my Mose fellowship, they only used boric acid to treat AKs. They did not use cryosurgery. They did not use TCA. All they did was the boric acid all day long, dabbing with the Q-tip on the AKs. I never forget that. So boric acid is not that toxic. Now, and this is tavabrol. It actually inhibits leucine T RNA synthetase, and that's how it works. That's how it kills the fungus. And when you look at the results, those are the pivotal studies that got the drug approved. The numbers are not that impressive, again, but also remember the clinical cure rate is pretty high. It had to be always clear, and that's difficult to achieve clinically for the toenail to be 100% clear. Two different studies, parallel run, the same inclusion-exclusion criteria, about 6.5 and 9.1. It is on the low side. But if we take completely clear and almost clear, but in this case, almost clear defined as less than 10%, not less than 5%. Remember, on the previous study was less than 5%. This is defined as less than 10%, so the numbers go up about 26 to 27%, just like the other product. But there's a difference on the definition of the almost clear, less than 5% on the other study, less than 10% on this one. So bear that in mind, and that gives you an idea of exactly how we are evaluating those. Mycologic cure rate was about 31, 35%. So again, another addition to our armamentarium for the treatment of toenail onychomycosis. Couple of the pictures here. This is an all clear picture, pretty nice. And finally, the lasers. I really am not a laser guy. I do mostly medical dermatology, but the lasers are coming for onychomycosis. I looked in the literature, not much going on. The only thing I was able to find out, respectable journal, respectable authors, respectable study group by Bani Oluski at Judd, and the bottom line was that NDYAC really did not work for treating onychomycosis. So I think we need much work to do on the laser treatment or the heat treatment for onychomycosis. From the feet, I'm going to the face. So we're moving up to the face. What do we have new in the rosacea arena? As you know, we had about a year ago or a year and a half ago, we got brimonidine for the type 1 erythrometelangiectatic rosacea for background redness, but that is certainly not enough to treat papulopustular rosacea. So papulopustular rosacea is a whole different game, and we have not had much since metronidazole and azelaic acid. So now we have a new treatment for papulopustular rosacea, ivermectin 1%. And the results are pretty impressive here. First of all, the inclusion criteria was moderate to severe rosacea with a quite high numbers of starting point. The baseline number of lesions were very high compared to metro or azelaic acid or even oracea in the beginning. And the number here, inflammatory lesion reduction, is 76% and 75%. Again, I always like to show two different studies, parallel run studies. One is 76, one is 75. And you see the numbers are so beautifully aligned in both studies. The vehicle effect is about 50%. And guess what the vehicle is here? It's Cetaphil cream. and you know the positive impact of Cetaphil cream on the skin. So of course, it is gonna have a pretty good impact that adds to the ivermectin 1% to the active in itself. It doesn't take it away. Just because you have a good vehicle effect, that doesn't mean that the drug doesn't work. It actually adds to the active drug, and it helps the skin barrier. You heard this morning a lot about epidermal barrier function and how rosacea patients have impaired epidermal barrier. So fixing the barrier is half of the challenge. With Cetaphil cream, you're accomplishing that. On top of that, you have the ivermectin 1% there. So that's 75, 76%. The numbers are beautifully aligned. Really a nice design, nicely executed study. Very impressive reduction. We never had so much inflammatory lesion reduction in any other topical rosacea drug. Neither in oracea, even in oral medication, neither in oracea nor in metro or azelaic acid. Couple of the pictures here. This is a severe patient, IgA of 4, because she had couple of 2 lesions left, so we could not rank her as IgA of 0. She had to be 1, almost clear. And if you look at the lesion reduction from 63 to 2, and if you do the math, that's 97% lesion reduction. So the next one is about 96% lesion reduction, and again, that's IgA of 4 going down to IgA of 1 because he had only 2 bumps left. Now, you can say that that's great, but give me a reason. Why should I change from my gold standard of treatment, Metro, right? Metro, unfortunately, because it's generic, it is the most commonly used rosacea drug, both in North America as well as in Europe. And not the 1% that we have here, but the 0.75%, the old Metro, it's still the most commonly used drug. So what Galderma did actually, they had the guts to have a head-to-head study, Metro 0.75% versus ivermectin, and everybody wants to know why did they pick Metro 0.75%? This was a European study. They don't have the Metro 1%, so they had to pick the 0.75%. Also, it is the most commonly used topical rosacea drug. So when you look at that head-to-head study for 16 weeks, 83% versus 73%, 10% gap. And from week 3, there is actually a statistically significant difference between the 2 arms, early onset of action for ivermectin, but you can see the gap is widening as you go along. Week 6, week 12, week 9, week 12, the gap is widening as you go along. This study has a second part, part B, for maintenance, and actually there was much big difference between Metro and ivermectin group. Patients in the ivermectin group, it took them 115 days to relapse, versus Metro was 85 days. So actually there's a whole month of difference for relapse between the ivermectin group versus the Metro group. So it's not only working at the onset, but it's also working when those patients off the drug for maintenance, that there was a whole month of difference between the 2 groups. And this is from the European study, Metro versus ivermectin. You can see this lady with IgA of 3, basically that was moderate, and she came down to 0, absolutely clear. We're gonna stay on the face and move on to acne. The new acne product we have is the benzoyl peroxide 3.75% with clindamycin 1.2%. And that was an aqueous gel in moderate to severe acne. And here, vehicle is very, very important. As I always mention, vehicles do matter because you can have the best active molecule. If it doesn't go through the stratum corneum, it's not gonna do the job. Or it can go through the stratum corneum and irritates the patient. Nobody is gonna use it. So there is nothing more critical than the vehicle when it comes to topical treatment. So in this case, this gel, it's not your grandfather's gel. It's not full of alcohol. It's actually aqueous gel. It has humectant in it, propylene glycol. Propylene glycol in the right concentration. It has a great penetration enhancer. Will carry your active down to through the stratum corneum, which is a formidable, impassable barrier. It's gonna get to where it's supposed to get. On top of that, It has a humectant effect, meaning that it brings the water from the bottom layer of the skin to the top. It has a humidifying effect. pH of 5 and 6, close to the skin pH, so that's important, and no preservatives, no surfactants, so that makes it a very valuable vehicle. What's in it? Actives are clindamycin, and in this case, it's actually water-soluble ester of the clindamycin, so it's fully dissolvable. I don't use clindamycin alone as monotherapy anymore. I think we have to be mindful of the bacterial resistance. It's very important. It's crucial. We all have to be good antibiotic stewards. There is a program tonight, I think, or tomorrow on that. I think it's really important. On the other hand, if you use it with benzoyl peroxide, it will inhibit, it will prevent that antibiotic resistance. So it's not a big whoop as long as we are not using it as monotherapy. Benzoyl peroxide, as you know, it's the grandfather of all acne treatments. It's the best acne treatment that we have. But if you go buy it at Walgreens and CVS, it's in horrible vehicle. It doesn't go through the stratum corneum. It doesn't go through the pilosebaceous unit. I actually have pictures of electromagnetic pictures that shows, electron microscopy, sorry, that shows that the generic benzoyl peroxide, the white crystals you see sitting on the skin, it doesn't go anywhere and it irritates the skin, so it doesn't work and it irritates. You have the right micronized benzoyl peroxide, it's gonna go through the pilosebaceous unit. So in this case, 90% of the particles are less than 10 microns. And it is about 166 microns, the opening of the pilosebaceous unit. So right there and then you have a good entry point, and they will go in there and they will do their job. So benzoyl peroxide is the best acne medication if you can make it go through the pilosebaceous unit. And of course, it's not only bactericidal, so it's complementary to clindamycin to prevent antibiotic resistance, but it also has anti-comedogenic effect, and even some people say it has anti-inflammatory effect that adds to the anti-inflammatory effect of the clindamycin. So it's a win-win situation for those two drugs to be together and actually address 3 out of the 4 pathophysiologic mechanisms of acne. Moving on, if you look at the numbers, you can see that non-inflammatory lesion count is about 52%, and inflammatory lesion count is about 60% here. And 2-grade improvement overall severity score, 35% versus placebo, and there is no placebo in topical treatment, I should say the vehicle, 17%. I don't do much cosmetic stuff. However, when I see something interesting on the cosmeceutical that works, I pay attention. So we're staying on the face, we're staying on the photo damage and the wrinkles. So this is actually a glycoaminoglycan secretion from a snail. I thought that was interesting.